Okay, hello, my dear students again, and we will continue with our lecture regarding hemodynamic disorders because we have only two questions left, embolism and disseminated intravascular coagulation. 1 minute, I will start with embolism. Hope Dropbox will allow us to download all the remaining information. So, embolism, it is a transport of abnormal mass in the bloodstream that results in partial or complete vascular occlusion leading to ischemic necrosis. And you remember from topic number 1 that ischemic necrosis, it is infarction. Embolism can be classified according to the matter that is transported inside of bloodstream. And if the particles are solid, they may be thromboemboli, parts of erythematous plaque from atherosclerosis of vessels. They may be tumor cell in context of metastasis of malignant tumors, or tissue fragments like fragments of vegetations that may appear on the cusps of the valves in case of bacterial endocarditis. Also, it may be liquid. Two types are included here: fat globules and amniotic fluid embolism, and gaseous. In this case, it may be air or some other gases like nitrogen that we will see in case of decompression sickness. Depending upon presence of microorganisms, emboli may be blind if they are sterile and septic when they are infected. According to direction of embolism spread, they may pass from cardiac, from heart, and in this case they will be called as cardiac emboli. They may spread according to bloodstream from the larger arteries to the smaller arteries. For example, from aorta, emboli may pass, thromboemboli usually may pass to smaller arteries of internal organs. Venous emboli, they spread from deep veins, usually of lower extremities, through system of inferior vena cava, through right chambers of the heart, into pulmonary arteries. Also, in literature, lymphatic emboli are mentioned, but this condition is very, very rare, and to tell you the truth, I don't know exactly what is it. Maybe just spread of malignant cells in case of metastasis. Also, there are specific types of embolism. Paradoxical embolism. It is when embolus, you remember normally that physiologically and anatomically, our arterial blood flow is separated from our venous blood flow. But if, for example, patient has defect, usually congenital defect of the heart, like defect in intraventricular septa or patent foramina valia, that is a defect in between intraatrial septa. In this case, emboli may pass from venous part of the body toward arterial directly through this defect. Also, term retrograde embolism means when particles, they travel in reverse direction of blood flow. Usually, of course, all the particles, they go according to the blood flow, they spread according to the blood flow. But if they are very heavy, for example, if bullet will be introduced into the bloodstream, in this case, of course, according to very heavy, as it is very heavy, it will drop down in reverse direction. So the most common type of embolism is thromboembolism. Also, depending on the direction of spread of thromboemboli, it may be systemic and may be pulmonary thromboembolism. Systemic thromboembolism, sometimes you may see such term as thromboembolic syndrome, and it is synonym for systemic thromboembolism. It is spread of thromboemboli within arterial circulation. What are the sources for these thromboemboli? They may be left chambers of the heart, usually in left atrium or left ventricle. Thrombi may appear if there is, for example, different arrhythmias that predispose for blood flow. If you remember from the previous lecture, sorry, what is Virchow's triad? It includes damage of endothelium, disturbance in blood flow, and hypercoagulability that results in formation of thrombi that later may become emboli. Also, thrombi in aorta, usually superimposed on atherosclerotic damage of the vessels, may become the source for thromboembolism. Sometimes it may be paradoxical emboli that may pass from veins through defect in the heart toward arterial blood flow. And thrombi may be superimposed on the cusps of aortic and mitral valve. I attract your attention that we are dealing with the valves in left chamber of the heart because we need to spread emboli to systemic circulation. These thrombi may develop here due to bacterial endocarditis. And effects of systemic thromboembolism, of course, occlusion of arteries, of small arteries that carry blood to the organ, results in infarction in these organs. Or, for example, gangrene of lower extremity. So we will deal with ischemic necrosis. Pulmonary thromboembolism. As I told you already, the main source for pulmonary thromboembolism are veins, especially veins of lower extremities or femoral vein, especially if they are affected with varicose, if we see varicose veins. Because varicose veins, they have dilation that again predispose for formation of turbulence of blood flow. Also, you see that veins in pelvis may be responsible for formation of thrombi, especially if there is some mass in pelvis minor from ovary, from uterus that will compress the vein, also provoking stasis or turbulence of blood flow. So on this photo, what you see, the mechanism how thromboembolus from lower veins of lower extremities passes toward iliac vein and then to inferior vena cava, then to right atrium, right ventricle, and from right ventricle it will pass to pulmonary trunk, causing occlusion of different branches of pulmonary artery. If you remember, pulmonary thromboembolism was already mentioned in this lecture in context of acute right-sided heart failure, because if such occlusion will occur, the pressure will suddenly increase inside of right atrium or right ventricle, then in right atrium, and then it will spread in the system of inferior and superior vena cava. So, depending on the size of pulmonary emboli, the clinical effects may be different. If the huge thromboembolus will be trapped at the zone of bifurcation, and such thromboembolus is picturesquely named as saddle embolus because it really looks like saddle over the horse. In this case, sudden death will occur because this area is very sensitive and provokes pulmocoronary reflex. If there is occlusion of large branches of pulmonary artery, in this case, your patient will also very rapidly die with symptoms of acute right-sided heart failure. Why it will happen during the previous slide I have already explained. If there is occlusion of small branches, in this case, for such patient, chances to survive, they increase. And in this case, as your patient will survive, but blood flow in these small arteries will be disturbed, as well as blood flow for the part of the lung that gets blood through these branches. In this case, we will see formation of hemorrhagic infarctions of lungs. And during the joining of infection, of course, your patient will get pneumonia around the focus of infarction. And when all these areas will be organized by fibrous tissue, in this case, even chronic cor pulmonale may develop during the time. Of course, if there is obstruction of small branches, but a lot of them will be obstructed, your patient anyway will die due to acute right-sided heart failure. For For example, on this photo, you see a huge thromboembolus that was trapped on its way from veins of lower extremities toward pulmonary trunk in right chamber of the heart. On this photo, you see why infarction in lungs is called as red, because the area is severely inhibited with hemolyzed RBCs, and you see clear border between normal alveoli and hemorrhagic infarction. Next type of embolism that is an example of fluid embolism, it is fat embolism. Fat embolism is a common complication of physical trauma, usually that is accompanied by damage of subcutaneous fat or damage of lungs bones with the release of fatty marrow. This fat embolism is very interesting and had widespread effects and very interesting pathogenesis. Because not only mechanical obstruction of small vessels, but also biochemical injury by fat globules plays role in this situation. Okay, let's imagine that fat globule has occluded the vessel. Platelets and RBCs will superimpose on these fat globules that will serve as a matrix for their aggregation. Additional release of fatty acids from fat globules will cause toxic injury of endothelium. And you remember that damage of endothelium, it is a risk factor for consequent thrombosis. That's why it will just worsen and aggravate deposition of platelets, inflammatory cells, and that's why occlusion will become more and more severe. Fat embolism syndrome includes not only pulmonary insufficiency, because you can imagine that usually fat globules will be reabsorbed from the place of injury in venous part of our circulatory system, and from venous part they will pass to right chambers of the heart and then to branches of pulmonary arteries. But also due to their semi-fluid condition, they may pass through capillaries and get lodged in systemic circulation, affecting brain, kidneys, and so on and so on. So for this type of emboli, it is possible to pass from venous part of our circulation toward arterial. And of course, as occlusion of small arteries will take place, finally we will see formation of microinfarcts or hemorrhages due to rupture of the vessels with a high pressure. On this photo, you see fat globule. It looks like empty space, and you remember why, with superimposed fibrin, inflammatory cells, thrombocytes, and so on and so on. On this photo, you see a Sudan 3 stain, positive stain for fat, that reveals these numerous fat globules in lungs. Also, Sudan 3 and presence of fat droplets in glomeruli of the kidneys. Next type of embolism, air embolism. Air embolism occurs when there is insertion of air in venous or arterial blood flow. Of course, again, presence of huge gas bubbles in the circulation provokes obstruction and of the blood flow and consequent ischemic injury. And to tell you the truth, when you make the intramuscular injections and you see small bubbles in the syringe, of course, these small bubbles, they are of no use. They are not dangerous. They will be very easily dissolved in tissues, as well as if they will pass to venous circulation. But if you will insert in the syringe 100 or 150 milliliters of air, it will be fatal, because the heart of the patient will make one empty systole and it will stop just due to this reflex. Of course, from veins, air will pass to pulmonary trunk through right heart and will cause obstruction of branches of pulmonary trunk. Arterial air embolism may occur as a complication of cardiothoracic surgery or trauma, or paradoxical air embolism, or during arteriography. Venous air embolism may occur if there is operation on head and neck. You remember that in veins in this area, the pressure is very low, or as a complication of obstetrical operation, because again, in uterus, in veins of uterus, pressure is lower as in case of, for example, in other veins. That's why you must remember that open veins of the neck may just reabsorb and soak the air by themselves. So you should not keep them open. Gas embolism is different from air embolism. In case of air embolism, the air from outside just enters the bloodstream. Gas embolism, it is different. This type of embolism occurs inside of the patient without any external insertion of some gas when there is sudden decrease of atmospheric pressure, and predominantly nitrogen is responsible for this type of embolism. It dissolves primarily in the blood, but when pressure decreases, it starts to produce bubbles within the circulation that obstruct small vessels and cause damage of the vessels. And the main example of air embolism is the compression sickness, because when patient breathes air in high pressure, for example, scuba divers, or if patient work on some underwater construction, like submarine, for example, or if there is aircraft that will drop and unpressure suddenly. In this case, increased amount of gas, as I told you already, usually nitrogen, it becomes dissolved, and when suddenly the decompression will occur, suddenly pressure will decrease. The nitrogen will expand and form bubbles that will block circulation. So, if clinical effects of decompression sickness is called as aeremia, presence of gas in the blood, and predominantly in this case, all the organs in pulmonary as well as systemic circulation will be suffered. You see that predominantly CNS, lungs, joints, skeletal muscles, and also bones will be suffered from ischemic necrosis due to occlusion of the vessels by bubbles. Amniotic fluid embolism. As I told you already, veins in uterus, they have very low pressure, and if, for example, there will be preterm detachment of placenta, in this laceration, air and amniotic fluid may enter, and through inferior vena cava, it will pass to right chambers of the heart and then to pulmonary circulation, causing obstruction. What is interesting, morphologically, of course, clinically, such patient will get sudden severe dyspnea followed by obstetrical complications. And morphologically, it is very interesting. Inside of the vessels, you will see specimens of the integuments of the fetus, like squamous cells that are shed from fetal skin, so-called lanuga hair. These hairs are the hair of the fetus. Fat that covers the skin of the fetus, and of course release of all this material provokes marked damage of alveoli with formation of diffuse alveolar damage. For example, here you see that some substances are seen inside of the vessels as particles of the fetus. Also, I should mention erythematous embolism as an example of solid embolism, I think. It is material that is detached from erythematous plaques that are deposition of cholesterol inside of the vessels in such disease as atherosclerosis. Destruction of these plaques may provoke arterial embolism in the direction from larger arteries to smaller one. And here you see such occlusion. Tumor embolus. This type of embolism we will discuss in context of metastasis. So malignant tumors may spread within circulation through lymphatic and blood vessels, causing formation of secondary implants and formation of secondary tumors. And the last point in our lecture, disseminated intravascular coagulation. Very interesting and life-threatening condition. And definition of this condition covers all the pathogenetical situation that occur during its activation. So this condition is characterized by systemic activation of pathways regulating coagulation, which can lead to formation of fibrin clots and with consequent organ failure and the concomitant consumption of platelets and coagulation factors with clinical bleeding. So when we will discuss the stages, I think you will understand what this definition covers. So DIC never can be a primary disease. It is complication of many other diseases. And if you will look at the list of the etiological factors, you must remember that all that may activate DIC is a release of tissue thromboplastin. Infections. You remember from shock that release of endotoxins provoke systemic damage of endothelium due to release of cytokines. Also, obstetrical syndromes. You see that in this case, again, there is damage of the tissue of the mother or retention of dead fetus that again is a source of release of tissue thromboplastin. Neoplasm, due to their destruction, release of tissue thromboplastin may be. And all these points, they are associated with tissue thromboplastin. Why I mentioned this factor, because tissue thromboplastin is normal physiological factor that starts coagulation. That's why if something will go wrong, this release will be accepted by the organism as a response, as a damage that should be treated. DIC it may have acute course or chronic course. In case of acute course, usually we see that symptoms of bleeding with consequent shock will dominate. And in case of chronic DIC, that usually accompanies patients with malignant tumors. In this case, vice versa, phase of hypercoagulation will dominate with formation of infarctions and embolism. There are 4 phases of DIC. First phase is phase of hypercoagulation and formation of thrombi after the release of tissue thromboplastin. The second phase is phase of hypercoagulation because all the factors of coagulation were exhausted during the first phase for formation of numerous thrombi. Phase number 3, activation of fibrinolysis. You remember that any thrombus physiologically then should be dissolved, but in this case, this physiological mechanism plays very bad role because patient already has coagulopathy with tendency to bleeding, and additional activation of fibrinolysis provokes just worsen this bleeding. And the phase of outcome. So, what happens during the first phase? As I told you already, release of tissue thromboplastin due to above-mentioned etiological factors, it starts blood clotting everywhere. Also, release of biologically active mediators worsens this coagulation and causes blockage of microcirculation in numerous organs due to formation of microthrombi. Sorry. In phase 2, as I told you already, there is exhaustion of platelets and fibrinogen because they all were spent for formation of microthrombi. And that's why hypercoagulability will change to hypocoagulability, and it will, of course, lead to hemorrhages. In phase 3, there is physiological activation of fibrinolysis, but unfortunately it's too late. And As these primarily formed thrombi will be washed out from the circulation by fibrinolytic system, of course it will worsen bleeding, and also the organs that were affected, and in these organs during the first stage microinfarction were formed, they also will additionally may become the source of bleeding due to, for example, bleeding due to hemorrhage per diabrosin, if you remember what is it, due to corrosion of the vessel wall. So finally the bleeding will become more intensive. And phase 4 is phase of outcome. To use the truth, usually outcome is unfavorable, and DIC usually finishes with death. On this photo you see small thrombi and not so small thrombi as a manifestation of phase 1 of DIC syndrome. Also, small thrombi inside of capillary loops of glomeruli as widespread coagulation. So we have finished, fortunately, with hemodynamic disorders. See you next week for classes with being prepared with your questions. To tell you the truth, if you will find in internet some micro and macroscopical photos that you want to be explained, I mean the photos for the topic that we will discuss, to share with your classmates, I will be glad to explain and to discuss the photos.